There's a lot of observational data showing that acute stenting leads to better outcomes in these patients. However, it's very important to remember that observational data can be severely biased by indication, meaning that the decision to stent a patient might be influenced by how well the patient is and how well the procedure went. So let's say the interventionist might feel much more comfortable to stent a patient that is healthier, that is younger, that doesn't have so many comorbidities, and for which the thrombectomy went really well, there were no complications. Then they might say, oh no, I'm also going to treat the carotid artery right away, while on the other hand, the patient that is more critically affected or that didn't have a very successful thrombectomy, they might feel less inclined to treat. We look at that into our data because we have this information. And what we do see is that that doesn't appear to be the case. The baseline differences are very similar between both groups. The only major difference is the stroke etiology, meaning that actually what might influence the decision to stent in our data was the cause of the stroke. So if the interventionist really had no other explanation other than a tandem lesion, they really think the tandem lesion was the cause of the stroke, perhaps they are more inclined to treat. But in terms of procedural success rates and procedure number of passes, treatment time, it was very similar between both groups. We also did an analysis, well, which is not perfect, but is a kind of pseudo-randomization called inverse propensity to treatment weighted analysis, and we still see a benefit of stenting in this population. So I think this is very motivating for all the ongoing trials which might confirm this point in the coming years.